Dr. Pooja, if all the presenters are available, can we proceed with the free paper session? Or?
Yes, I think we can. I just messaged Dr. Alan Kumar and has said yes, we can.
Okay, fine.
Dr. Mohammad Alwan, are you here? Is that first on the list?
Yes, ma'am. Hello, good afternoon, ma'am.
Good afternoon. We would like to start.
Yes, ma'am. Okay. Shall I share my screen, ma'am?
Yes, please. Is it okay, Dr. Pooja?
Yes, ma'am. We can start.
Okay. Thank you.
Good afternoon. Are my slides visible, ma'am?
Yes.
Okay. So, good afternoon. My topic, my free paper topic is prevalence and severity of dry eye disease in type 2 diabetics. As we know, dry eye disease is one of the most common ophthalmic conditions, and diabetes is one of the most leading cause of blindness in 20 to 74-year-old patients. Cataract and retinopathy are well-known complications of diabetes, and recently, problems involving ocular surface, dry eyes in particular, have been reported among diabetic patients. My study is a cross-sectional study. Done between November 2019 to June 2021, and it was done in 100 type 2 diabetic patients attending the Department of Ophthalmology. Inclusion criteria was all the patients with type 2 diabetes mellitus attending the OPD of our Department of Ophthalmology, and exclusion criteria were cigarette smoking, contact lens users, allergies, and patients taking medications like antidepressants, antihypertensives, antihistaminics, diuretics, and oral contraceptives. Methodology: the detailed history was taken, the visual acuity was tested by Snellen's chart, detailed anterior segment examination was done with slit lamp, and these were evaluated using OSDI questionnaire, and Schirmer's test was done. Then tear breakup time measurement was done, and detailed fundus examination was done, and dry eye was graded based upon the dry eye grading scheme, and diabetic retinopathy is graded according to the ETDRS criteria. The investigations done were FPS, PPBS, and HbA1c. Analysis and results. Age distribution: most of the patients were between the age group 51 to 60 years, and most of the patients were males. 74% were males. And duration of diabetes: mean duration was 7.17 years, with most of the patient below having duration of diabetes less than 5 years. And coming to biochemical investigations, most of the patients had a HB level between 5.6 to 7%, followed by HbA1c level more than 8%. And OSDI score, around 21% of the patient had OSDI score between the mild and moderate range. Next, prevalence of the dry eye, it was 47% in our study. And grading of the dry eye, most of the patient had grade 1 dry eye, which was 49%. And distribution of diabetic retinopathy, most of the patient had mild NPDR. And we studied correlation between dry eye syndrome and duration of diabetes. The p-value was found to be less than 0.005, which was highly significant.
Just a minute. If the others could mute yourself, I think it would be nice, because it will be difficult to listen to the presenter. Yeah, I think you can continue. Yeah.
Coming to correlation between HbA1c and level and severity of dry eye syndrome, the chi-square test was less than 0.001, which was highly significant. And relation between dry eye syndrome and diabetic retinopathy, the p-value was 0.002, which was found to be highly significant. We compared our studies with other Indian studies. The prevalence of the dry eye in our study was 47%, whereas in study by Banwes et al, it was 60%, and Syed Ali Nasir Waris et al, it was 43%, and Manved et al, it was 54%. So it correlates roughly. And in our study, majority of the patients had grade 1 dry eye, and in other similar studies also, there was a grade 1 dry eye. And other studies have also found there is a significant relation between dry eyes and duration of diabetes, and dry eyes and HbA1c level. Conclusion: 47% of the type 2 diabetics had dry eye syndrome, and most of the patient had grade 1 dry eye. And significant association was found between duration of diabetes, glycemic control, diabetic retinopathy, and dry eye disease. Hence, dry eye evaluation should form an integral part of ocular examination of diabetic patients. Thank you. Hello, ma'am.
Yes.
I'm done with my presentation.
Yeah. Dr. Soumya?
Anything, Dr. Sandhya, anything? I think that was a nice presentation.
Thank you, ma'am.
The severity of dry eye syndrome in type 2 diabetics, and we all know that that forms a very important part in the diabetic eye disease. Anything else you have? You want to ask, Dr. Sandhya?
I just had one thing. I agree. What you presented is very extremely good. Okay, we had the correlation with HbA1c as well as the type of retinopathy. I wanted to know systemically if they had any other symptoms of polyneuropathy, because one of the factors which we expected to be causative would be autonomic neuropathy or other symptoms systemically.
No, ma'am. Actually, these were they had come to OPD. They were not admitted for anything as such. They didn't have any.
But polyneuropathy just has to have, peripheral neuropathy features. They don't need to be admitted or severe.
Yeah, ma'am. No, ma'am. No, in my study, as such, no patient had polyneuropathy.
That you could try and correlate with. Gives
Okay,
us,
ma'am.
Insight in. But
Okay,
otherwise, thank you for it. Nice.
Okay, thank you, ma'am. Thank you.
Dr. Anusha, are you ready with your presentation?
Yes, ma'am.
Yeah.
Can I present, ma'am?
Yeah.
Yes, ma'am. My slides are visible, ma'am?
Yes.
Okay, ma'am. Good afternoon, everyone. Myself, Dr. Anusha J. My moderator was Dr. Anita S. Mayama. Topic is correlation of peripapillary RNFL thickness with glycemic control in diabetics. Coming to introduction, diabetes mellitus is a multifactorial metabolic disease characterized by sustained hyperglycemia, leading to ocular complications such as diabetic retinopathy and macular edema, which can ultimately result in irreversible blindness. As per the American Diabetes Association recommendation in 2015, HbA1c levels, which reflect the average plasma glucose over the past 2 to 3 months, can be an effective tool to predict patients who are prone to develop complications like diabetic retinopathy. Also, the delayed detection of diabetic retinopathy may be attributed to the lack of awareness in the people about diabetic retinopathy and also inadequate screening, and due to the fact that it remains asymptomatic in the early stages, which are shown to be detected by optical coherence tomography (OCT) with the help of measurement of peripapillary RNFL thickness. Retinal neurodegenerative changes in diabetic retinopathy have been shown to precede microvascular changes in some previous studies, also known as diabetic retinal neurodegeneration caused by neuronal apoptosis glial cell activation, resulting in thinning of peripapillary RNFL thickness even in the absence of diabetic retinopathy progression. Therefore, the measurement of peripapillary RNFL thickness by OCT helps in the early detection of DR. Our study with the main two objectives, such as to compare the peripapillary RNFL thickness of type 2 diabetics with the normal subjects, and also to compare the peripapillary RNFL thickness of diabetes with the duration and HbA1c levels. Coming to methods and objectives, this was a hospital-based cross-sectional study included patients attending OPD. Inclusion criteria were patients above the age of 40 years with type 2 diabetes mellitus and willing to give consent. Also, the patients with ocular diseases like optic neuropathy, ARMD changes, glaucoma, uveitis, vascular occlusive diseases, tractional RD, diabetic macular edema, proliferative diabetic retinopathy, congenital optic disc anomalies, ocular injuries, and people with media obesities were excluded from our study. Systemic diseases like hypertension was excluded. Poor OCT signal strength less than or equal to 6 were excluded, and also high refractive errors with spherical and cylindrical lenses more than plus or minus 3 diopters were excluded from our study. Therefore, the patient were divided into 3 groups, A, B, and C, each having 20 subjects. Group A consisted of normal subjects. Group B with well-controlled diabetes, that is HbA1c levels less than 7. Group C consisted of impaired glycemic control subjects, that is HbA1c levels more than 7 gram per cent. All the subjects underwent a comprehensive ophthalmic examination of anterior and posterior segments with the staging of diabetic retinopathy. This was followed by peripapillary art NFL thickness measured by Siraj HT OCT through dilated pupils by Optedisc cube. And also it was recorded in all the 4 quadrants with average peripapillary art NFL thickness. Central macular thickness was assessed with the help of macular cube. HbA1c levels was measured among the diabetic subjects. So, total of 60 patients were studied during the period between Jan to September 2021. This was the table 1 showing demographic data. Age-wise distribution was divided into 40 to 44 years, 45 to 49 years, and more than 50 years. Duration was divided into less than 10 years of diabetes and more than 10 years of diabetes. This is the table showing comparison of mean peripapillary art NFL thickness among the groups in superior, nasal, inferior, and temporal quadrants. Results. Comparison of peripapillary art NFL thickness between normal and diabetic subjects was done using independent t-test, where it showed a significant reduction in the average left eye peripapillary art NFL thickness in the diabetics compared to the normal subjects, irrespective of the diabetic retinopathy staging. It also showed significant decrease in the superior and inferior quadrants in the diabetic subjects. And next, comparison of peripapillary art NFL thickness between well-controlled and uncontrolled diabetes was also done using independent sample t-test. It also showed a significant increase in the peripapillary art NFL thickness in the temporal quadrants and decrease in the superior quadrants in the left eye compared to controlled diabetes. Pearson's correlation between peripapillary art NFL thickness and HbA1c showed a significant positive correlation in the temporal quadrants in the uncontrolled diabetes. There was no significant difference in the duration of diabetes mellitus and central macular thickness in diabetics compared to peripapillary art NFL thickness. Discussion. There was a significant reduction was present in the average RNFL thickness between diabetics when compared with the normal subjects, irrespective of diabetic retinopathy, which was similar to the previous study of Chetziwali et al. Early diabetic retinal neurodegeneration can be attributed to various factors resulting in neurodegeneration from metabolic derangements, reactive gliosis, glutamate excitotoxicity, and nerve fiber layer and ganglion cell apoptosis, which finally results in thinning of peripapillary RNF. As these changes are picked up early by optical coherence tomography, early detection of DR is made easy to prevent further complications of DR and initiating appropriate therapeutic approach. In the present study, the thickness of peripapillary RNF was significantly increased in uncontrolled diabetes, which may be attributed to the breakdown of the inner blood-retinal barrier and leakage of serum proteins into the intraretinal space, resulting in intraretinal edema from resulting inflammation. There was a positive correlation between HbA1c levels with the peripapillary RNFL thickness in the temporal quadrant in the uncontrolled diabetes, making sure that HbA1c level can be used as an effective marker of DR severity, similar to the previous study of Sugimoto et al. And also the previous studies showed with each 1% reduction of HbA1c level, there can be 40% reduction in the development of systemic and ocular complications from diabetes mellitus. Now coming to conclusion, that is peripapillary RNFL thickness loss occurs in diabetes even in the absence of diabetic retinopathy progression. Peripapillary RNFL thus be used to monitor early retinal changes in diabetics and also as a predictor of diabetic retinopathy development, which can be used to prevent diabetic retinopathy related blindness. Impaired glycemic controls affects peripapillary RNFL thickness. Thank you.
Yeah, Dr. Anusha, I think that was a good presentation. And what I could get from your presentation was like a lot of parameters are used in your study, I guess. So
Yes,
you have used the systemic factors like HbA1c. You have also used the peripapillary retinal nerve fiber layer thickness, and also you have tried to compare the uncontrolled with the controlled diabetics.
Yes, ma'am.
And things like that. So what about this right eye, left eye? I just wanted to know. I mean, I was really curious to know. So you said in some of the patients, the left eye showed.
Yes, ma'am. Compared to when coming to comparison between controlled and uncontrolled diabetes, there was significant reduction in the increase in the temporal quadrants in left eye.
Okay.
One eye it was increased thickness was observed, and other eye it was significant decrease compared to control diabetes. Maybe the increased thickness is due to resulting inflammation and blood retinal barrier break, resulting in intraretinal edema as the DR progression increases.
These diabetics, they were also hypertensive, is it? Like, or you have
No, ma'am.
excluded
Hypertension was excluded from our study, ma'am, because it may.
Yeah, that's what. So that's what I wanted to know. Yeah.
Yes, ma'am. Hypertensives were excluded from our study. Only diabetics.
Anusha?
Yes, ma'am.
Dr. Anusha? Yeah, you should have included even the OCT images in your slide. So that would have been better, I feel.
Okay, ma'am.
Sandhya, anything you want to add, Dr. Sandhya?
No, ma'am, that's fine. I think.
Thank you, ma'am.
Yeah. Thank you. Can we have Dr. Arya presenting her free paper? Dr. Arya, free paper 1553.
Yes, ma'am.
Yeah.
Is my screen visible?
It's visible, but I think your voice is breaking. So if you could have a stable connection.
Is it
Yeah,
better now?
I think now it's fine. Yes.
Okay. Good afternoon, everyone. I'll be presenting a paper titled Analysis of Risk Factors for ROP in AJ versus SJ preterm infants in Karnataka. I'm the presenting author, Dr. Arya Vagle. My chief author is Dr. Sulata V. Bhandari, and my co-author is Dr. Leslie Lewis, who's a neonatologist. Retinopathy of prematurity is a leading cause of potentially avoidable childhood blindness worldwide, and its incidence is increasing with increased survival of infants born at very early gestational ages. Knowledge regarding the risk factors may help in early diagnosis and modification of the risk factors wherever possible. Early detection and early initiation of treatment remain the main weapons in the battle against ROP. AGA stands for appropriate for gestational age, and their birth weight falls between 10th and 90th percentile for that gestational age. SJ babies are small for gestational age and their birth weight is less than the 10th percentile for that gestation. The aims and objectives of my study were to compare the risk factors and severity of ROP in AJ versus SJ babies to study the antenatal, natal, postnatal risk factors for ROP in these preterm babies. Inclusion criteria was the gestational age at birth of less than 36 weeks and a birth weight of less than 2,000 grams. If they were above 36 weeks or a birth weight above 2,000 grams, if they were considered high risk for ROP, they were included. This was according to the pediatrician's discretion. Neonates were followed up until regression of treatment, regression of ROP or treatment completion. Exclusion criteria included loss of follow-up before complete regression or treatment completion, incomplete data in case of referred babies from outside, and parents unwilling for the study. It was a prospective study with a study period from August 350 babies, and data was collected from the records of these babies screened by a single examiner with an indirect ophthalmoscope in the NICU and follow-up in the Eye Ocd. Retinopathy was created based on the international classification of ROP, and babies were followed up till complete vascularization or till complete regression of the disease. Treatment was initiated for indicated babies. Data analysis was carried out for incidence, risk factors, and the severity of the disease. The risk factors that we looked at antenatally were multiple gestation, antenatal neuroprotection with magnesium sulfate, steroid prophylaxis, chorioamnionitis, maternal comorbidities. Natal risk factors were resuscitation at birth, respiratory distress syndrome, a poor Apgar score, presence of intraventricular hemorrhage, low birth weight, and exposure to oxygen therapy. Postnatal risk factors were the use of pulmonary surfactant for respiratory distress syndrome, packed RBC transfusion, presence of sepsis, and presence of early postnatal hypo or hyperglycemia. Coming to the results and discussion, out of the 350 babies examined, 260 fell under AGA and 90 babies fell under the SJ category. In the AGA, there was no ROP in around 63% of the babies, where ROP was present in around 37%. Out of these babies with ROP, treatment requiring ROP was around 4% in the AGA category, and the rest regressed spontaneously. Out of the 90 SGA babies, there was no ROP in 55% and presence of ROP in 45% of the babies. Out of these, the treatment requiring ROP were around 8%, which is almost double of that of the AGA category, and the rest regressed spontaneously. ROP fortunately regressed in all eyes after laser photocoagulation treatment. This is the distribution of the birth weight of all the babies examined. In the AGA category, the mean birth weight was around 1521 plus or minus 369 grams, with a mean gestational age at birth of 30.99 plus or minus 2 weeks. In the SGA category, mean birth weight was 1326 plus or minus 364 grams, and mean gestational age at birth was 32.8 plus 2.9 plus or minus 2.9 weeks. The analysis of the risk factors antenatally, it revealed that multiple gestation was found to be significant in AGA and SGA category. And in the natal risk factors, we found that a low APGAR score at 1 minute of life had a significant p-value for AGA as well as SGA category. Postnatally, if the baby received any packed RBC transfusion, the presence of sepsis and presence of respiratory distress, all of these had a significant p-value in both AGA and SGA categories. So coming to the conclusion, in our study, we found that being SGA is a risk factor for the development of ROP, as the incidence of ROP is higher for SGA in our study. Severity and treatment requiring ROP incidence was also higher in the SGA category. And being born at an early gestational age, low birth weight, these were also found to be significant as seen in previous studies which have been published. Multiple gestation, low APGAR at 1 minute of life, presence of respiratory distress were found to be significant in the development of ROP in our study. And there were no significant differences in the risk factors between the AGA and SGA category. These are my references. Thank you.
Dr. Anusha, can you hear me?
Hello. Yes,
Hello.
ma'am, I can hear you.
Yeah. So it was a nice presentation. Okay, I mean, it's an important topic, something which we still need to create awareness, though the incidence of ROP has come down over the last few years. I wanted to know a couple of things. One, can we go back to the slide where you showed the percentage of regression, comparison of AGA and SGA?
Yes.
Pie chart. Yeah, so this one, on the AGA side, we know that 4% treatment requiring ROP and 96% spontaneously regressed.
Yes.
But on this side, we have 8 and 8%.
Yeah, that is at 92. It's a mistake on them.
But if we see
92%.
Okay, fine. So actually, I wanted to know, is gestational age was found to be a bigger risk factor, or the birth weight as an AGA or SGA was found to be the bigger risk factor? Because if you see SGA, they are like mean age was about 32 weeks, and in AGA, the mean week was around 30 weeks, isn't it? So they are comparatively younger. So
there we found that SGA at any gestational age were at a higher risk for ROP, because they are small for gestational age, and intrauterine, most of them have growth restriction. When they are born, they require more oxygen, and they are actually not able to tolerate enteral feeds also very early. So the early feeds are not possible, and there are many other requirements that and they undergo additional treatment from the pediatrician side as well.
So all
So
that
they
adds risk factors for developing ROP. Okay.
Yes.
Fine. The second thing is you said some of them were more than 36 weeks and more than 2 kgs, isn't it? Can you list me the requirements? I mean, what was the risk factor for such babies that they developed ROP, which were included?
If the birth weight is more than 2000 and if they are born earlier than 32 weeks, then we took them. Or if the less than if they were more than 36 weeks and still less than 2000 grams, then we took them.
Yeah,
We included them.
there were some which were more than 36 and which were more than 2, but they had additional risk factors.
Yes, ma'am.
Something requiring treatment, maybe.
Yes.
Were they like very complicated anomalies or something?
Most of them actually were multiple births. So twins, usually we always take them into the NICU. So they do undergo ROP screening.
Okay.
In addition to what Dr. Sandhya was saying, that's what she was pointing towards, any systemic factors, like risk factors. Suppose if it's more than 36 weeks gestation and a lower birth weight, were they associated with any respiratory distress syndrome or hypoglycemia or septicemia? So all these all are risk factors wherein even if they're gone more than 36 weeks, we do take them for ROP screening. I think that's what Dr. Sandhya, you were indicating.
Yeah, correct. Right.
Yeah.
That's all from my
presentation. Yeah.
Thank you, ma'am. I'll stop sharing.
Yes.
Dr. Chandralekha, if you are ready with your presentation, can you just please present?
Yes, ma'am, I'm ready, ma'am. Yes, ma'am. Is my screen visible, ma'am?
No, not visible.
Oh, 1 second, ma'am. How about now, ma'am?
No, I think you have not shared your screen, I think.
Is it visible now, ma'am?
Yes.
Can I start, ma'am?
Yes.
Good afternoon, everyone. I'm Dr. Chandralekha from AJ Institute of Medical Sciences. We'll be presenting today my free paper on the topic association between level of serum uric acid and the grade of hypertensive retinopathy in hypertensives. My chief author being Dr. Jairam Shetty, sir. The objective of the study is to look for the association between serum uric acid levels and the hypertensive retinopathy and to assess the type of retinal changes in the hypertensive patients with hyperuricemia. Introduction.
I think you have muted yourself. Dr. Chandralekha, any technical issues?
We need to have phone numbers of everyone, I guess. It would be easier to call up and find out.
Yeah. If I don't know if she's not able to continue, can we have the next presenter? Saujanya, is that fine? So if she could rectify her this one and again come and present. Dr. Sandhya, Dr. Pooja, what do you say?
If the next person can share the screen, then maybe we can go ahead.
Yes, ma'am.
I'm not sure if 2 people can share.
I don't know, that's what, even I'm not sure about it. So that's why I just wanted to, I put a message also. I don't know if she could see the message, Dr. Chandralekha.
I think it's stuck for her.
Yeah, I think that's what. I think she has to stop. I mean, probably, I think even she couldn't. Yeah. Can't even stop, I guess. Next is Dr. Harshita, right? Dr. Harshita?
Yes, ma'am. I'm ready.
You can start off.
Yeah, I think you can start your presentation.
My screen is visible, ma'am?
Yes.
Okay. The slides are moving, right?
Yes.
Okay. So good afternoon, everyone. My free paper 136564 is on peripheral and macular polypoidal choroidal vasculopathy or PCV. And it's a retrospective comparative case series. Now, what exactly is PCV? It is a disease of the choroidal vasculature, which is characterized by a presence of multiple pseudosanguinous or hemorrhagic detachments of the RP with extensive intraretinal or subretinal exudation, commonly affecting the macula and the peripapillary region. Now, what is peripheral PCV? Peripheral PCV is a subset of a wider disease entity, which is peripheral exudative hemorrhagic chorioretinopathy or PEHCR, which is characterized by peripheral subretinal hemorrhage, sub-RP hemorrhage, subretinal fluid, and exudation. And this most commonly involves the temporal periphery between the equator and the ora. Now, why is it important to study the differences between the two? Now, in normal eyes, the choroid towards the fovea is comparatively thicker and it tapers off towards the periphery of the fovea on both sides. Whereas in a peripheral PCV, the choroid towards the periphery is thicker and towards the center it is thinner. So normally there's a bowl-shaped configuration, whereas in the peripheral PCV, it gives a club-shaped configuration on OCT. To the best of our knowledge, there have been no reports comparing the clinical and imaging features and treatment outcomes between eyes having peripheral PCV and macular PCV. Hence, we did the study to compare the clinical and imaging features and treatment outcomes in eyes having a peripheral and a macular PCV. Ours was a retrospective comparative case series wherein confirmed cases of peripheral and macular PCV between July 2017 and June 2021 confirmed on ICGA were included. Now on ICGA, a macular PCV normally is diagnosed as one or more polyps, which are identified on ICGA in the macular region. Whereas in a peripheral PCV, there are one or two polyps or more, maybe in the temporal periphery, which is away from the macula. We tried to exclude the patients with history of ocular trauma, inflammation, tumor, and development abnormality or higher myopia, and also patients wherein there was a condition which reduced the angiographic image quality, not allowing us to identify the polyps. We recorded the data according to patient characteristics, ICGA and FFA findings, macular OCT, and the treatments the patients had received. Our results were a little bit surprising to us ourselves. Now, the mean age in patients with peripheral PCV was much higher than those in the macular PCV group. Also, looking at the clinical features, the lens status, subretinal heme, hard exudates, mean number of polyps, and the identification of branch vascular network was much different in the peripheral PCV group than the macular PCV group. The OCT features, the macular OCT features showed that the involvement of macula by fluid, pigment epithelial defect, heme or exudation, and the subfoveal choroidal thickness was much more in the macular PCV group than the peripheral PCV group. Now, peripheral PCV patients were mostly treated with the transscleral cryotherapy and focal laser to the polyps, whereas the macular PCV group was mostly treated with anti-VEGF therapy. Now, this is one of the example cases from our study, wherein an 80-year-old patient presented with blurring of vision in the left eye with subretinal hemorrhage. And in the ICGA, you can see there's blocked hypersynescence with peripheral polyps. We treated the patient with 3 rounds of cryotherapy and 2 doses of anti-VEGF over a span of 3 years. And the patient has been following up regularly over 2 years and the lesions remain inactive. This was a macular PCV case in our study, wherein a 68-year-old patient presented with right eye subretinal hemorrhage along with blurring of vision, wherein on ICGA, you can see there's blocked hypersynescence due to subretinal heme and a few polyps which are present superior to the disc. Now, this patient was treated with 8 doses of intravitreal aflibercept anti-VEGF and 1 session of focal laser over a span of 3 years. And till now, this patient remains active. So to summarize our results, peripheral PCV is commonly seen in older age groups. Hemorrhagic features were more common than the exudative features in peripheral PCV group. The detection of branching vascular network on ICGA and identification of leakage from this network on FA are not frequently seen in the peripheral PCV group. The choroidal thickness at the fovea is thinner in eyes with peripheral PCV compared to the macular PCV group, and treatment of the peripheral PCV mainly involves direct treatment to the polyps. Our study had a few limitations, like a smaller sample size, and we also could not look at the peripheral choroidal thickness differences between the both groups, owing to the rarity of the disease. In conclusion, peripheral and macular PCV cases are 2 separate clinical entities having distinct pathogenesis, clinical and imaging features, and treatment outcomes. Also, further studies are needed to understand the pathomechanism in these distinct disease entities. Thank you. Ma'am, I've finished with the presentation.
Yeah, I think that was a very good presentation on the features of macular and peripheral PCV. Can you just go back to the slide where you showed the treatment strategies? What was the
Yes,
treatment
ma'am.
slide?
This one?
Yeah, this one. So
Yeah.
the anti-VEGF was higher in, I mean, the injections were given for macular PCV more than that of peripheral.
Yes, ma'am. Yes.
Okay, so the anti-VEGF used were all aflibercept only?
Yes, ma'am. In the macular group, we used aflibercept, whereas in the peripheral PCV group, wherever we had to give anti-VEGF, Eccentrix was given.
Okay. So by any chance, I mean, it's just a question, measuring VEGF levels or something like that would help to, would be of any consequence or would be of any significance in such cases to distinguish PCV and peripheral PCV and macular PCV? Because the response to anti-VEGF is much, I mean, in macular PCV, I think that was much better when compared to that of peripheral
Yes,
PCV. That's what
ma'am. Yes,
probably
ma'am. So the
something related
study,
to that. Yeah.
yes, ma'am. Ma'am, the response to anti-VEGF was definitely better in macular PCV.
Yeah.
Also, the reason that we gave more VEGF in the macular PCV and not in the peripheral group was the peripheral group, we were aiming to target the polyps directly with laser, since it was in the periphery, so we could do that.
The focal laser also was much more in
ma'am. Correct. Yes, ma'am.
What about the vitreous surgeries in peripheral PCV? What were the indications?
Ma'am, in our institute, we firstly start the patients with anti-VEGF therapy, with the laser or anti-VEGF therapy, and the patients which were included in the study, mostly they resolved with the cryotherapy itself. So they did not have to undergo any like pars plana vitrectomy or any other in surgery. So we were able to achieve resolution with cryo itself.
Anything else, Dr. Sandhya?
Vitreous surgery has been mentioned as a part of treatment.
Yes, ma'am. So the patients were in peripheral PCV where I have written vitreous surgery. So this was not basically because of the polyp itself. This was if there had occurred any other complication because of the polyp or because of any features. Yes, ma'am.
The amount of vitreous hemorrhage, a breakthrough
yes,
vitreous hemorrhage, would you see it more compared to peripheral, compared to macular?
Yes, ma'am. It was actually the vitreous hemorrhage.
Not be performed, is it?
Ma'am, I can't hear you.
Can you hear me
clearly
now? Can you hear me now?
Yes, ma'am. Yeah, it's clearer.
Were the patients with the breakthrough vitreous hemorrhage excluded because an ICG could not be performed?
Yes, ma'am. We could not see the imaging findings in those patients. Yes.
Right. But otherwise, I think the possibility is higher with peripheral PCV.
Of VH, yes, ma'am. So what we saw was if a patient with VH came, so it happened in a few like surprising cases wherein we operated for the VH and then we ended up finding polyps on table itself. Like we found PEDs and later on when we did the imaging for the patient post-op, we found polyps.
Right. So this happens, as you said rightly. What we also, I mean, once in a while, what we have seen is, you have imaging features, even the B scan and imaging features. Sometimes you think it's a tumor mass or it's like, subretinal, such large elevations. And on intraoperatively, you realize, yes, it is a very typical PCV picture.
Yes, ma'am.
I understand. Thank you. Fine.
Yeah, thank you, Dr. Harshita.
Thank you, ma'am.
Dr. Sahana, if you're ready, you can start your presentation. Dr. Sahana, free paper 1307.
Ma'am, this is Chandralekha, ma'am. Can I just try sharing my presentation and present, ma'am?
Yeah, okay, Dr. Chandralekha.
Thank you, ma'am. I'll just try sharing. Ma'am, is the presentation visible, ma'am?
Yes, it's visible.
Okay. I'll start, ma'am.
Yes.
Good afternoon, everyone. I'm Dr. Chandralekha from AJ Institute of Medical Sciences, presenting my free paper on the topic association between level of serum uric acid and grade of hypertensive retinopathy in hypertensives. My chief author is Dr. Jairam Shetty, sir. Objective: to look for the association between serum uric acid levels and hypertensive retinopathy and to assess the type of retinal changes in the hypertensive patients with hyperuricemia. Introduction: the association between serum uric acid levels and high blood pressure is well established. It was determined that each 1 mg per dl increase in serum uric acid contributes to a 20% increased prevalence of hypertension in a general population not treated with hyperuricemia and hypertension. Hyperuricemia also contributes to the development of hypertension from pre-hypertensive state. Here, it can be seen that hyperuricemia through crystal pathway and crystal independent pathway can cause endothelial damage or dysfunction, which causes hypertension. Materials and methods: it is a hospital-based cross-sectional study which is prospective in nature. All patients presenting with blurring of vision, headache, and known cases of hypertension were clinically examined and assessed. Informed consent of each patient along with patient's name, age, presenting complaints, and past history was taken. Patient was asked to rest, after which right arm blood pressure was measured in the sitting position. A detailed ophthalmic examination was done, which included fundus examination using ophthalmoscope following pharmacological dilatation of pupils, and patients were graded according to the Keith and Wagner's hypertensive retinopathy classification. The sample size collected is 20, and the study place is patients presenting to the outpatient department of ophthalmology at AJ Institute of Medical Sciences during a study period of 1 year. The patients were diagnosed as hypertensive for at least 1 year prior to the study and were started on antihypertensive drugs. Inclusion criteria: all consenting non-diabetic cases with hypertension who met a predefined criteria and those who are willing to undergo fundoscopy and serum uric acid levels examination visiting the outpatient department of ophthalmology at AJ Hospital between the study duration. Exclusion criteria: non-consenting cases, children less than 18 years of age, pregnant patients, patients not willing to give written informed consents, patients with any media opacities or any ocular trauma such as blunt and penetrating injuries, or any other history of other systemic illnesses. The results: the demographic data of my study shows subjects in the age group of 45 to 55 years are more than in 55 and above. Subjects are equally distributed among males and females. There are more subjects with duration of hypertension in less than 10 years of age than in 10 years and above. The frequency of grade 1 hypertensive retinopathy is more than grade 3, which is more than grade 2 hypertensive retinopathy stage. The above table shows the overall summation of grades of hypertension with age, sex, and duration of hypertension. The p-value for the above association is extracted by Fisher's exact test, which shows there is no significance with the grade of hypertension and age and sex, but there is high significance with the grade of hypertension and duration of hypertension. Now, to look for the association between serum uric acid levels and grades of hypertension, ANOVA p-value is used, which shows that there is a high significance between serum uric acid levels and hypertension. This table where there is x-axis which represents the grade of hypertension and y-axis representing the uric acid levels, the ANOVA p-value shows that with increasing serum uric acid level, there is progression of the grade of hypertension, keeping in mind the duration of hypertension. So here, as you can see, as there is increase of serum uric acid levels, there is progression of grade of hypertension retinopathy. Discussion. The ANOVA p-value shows high significance of association between the grade of hypertension and serum uric acid levels. Firstly, it has been clearly proven that there is a positive association between the two variables which are taken in this study. And secondly, along with increasing serum uric acid levels, there is progression of the grade of hypertension noted as well. Conclusion, based on these observations, it is noted that there is a positive association between increasing serum uric acid levels and corresponding grade of retinopathy in hypertensives. So the lowering of serum uric acid levels has become an intriguing approach in the management of hypertensive. Ma'am, can you hear me now?
Yeah.
Discussion. The ANOVA p-value shows high significance of association between grade of hypertension and serum uric acid levels. Can you see the presentation, ma'am?
Yes.
Yeah. Sorry, ma'am. Firstly, it has been clearly proven that there is a positive association between the two variables which are taken in this study. And secondly, along with increasing serum uric acid levels, there is progression of grade of hypertension noted as well. Conclusion, based on these observations, it is noted that there is a positive association between increasing serum uric acid levels and corresponding grade of retinopathy in hypertensives. So the lowering of serum uric acid levels has become an intriguing approach in the management of hypertensive retinopathy. Hence, all hypertensive patients should be advised to get their serum uric acid levels checked, and control of blood pressure level is necessary to control the progression of hypertensive together. Am I finished?
Yeah, Dr. Chandralekha, I think it was a neat presentation on
Thank you,
the correlation between, in spite of your having technical snacks,
yes,
it's a neat presentation of correlation of uric acid with hypertensive retinopathy.
Thank you.
Dr. Chandralekha, can you hear
Yes,
me?
ma'am. Yes, ma'am, I can hear you, ma'am.
Yeah, how did you further manage on patients who had rise in the uric acid levels? What did you start them on?
Ma'am, we, as of here, we didn't start them on any medication, ma'am. Firstly, we've sent them to general medicine department to get them evaluated further and to take a medicine opinion, ma'am.
Yeah, that's what.
So,
yes, how did you
ma'am.
further follow it up?
We didn't follow it up yet, ma'am. We've just forwarded them to the general medicine department, and we are yet to be followed about the management, ma'am. We didn't still know like what is good to go with about the management, ma'am. We found out that there is an association, ma'am. We further wanted to investigate them in about the serum uric acid levels and if any other systemic, is it causing any other systemic illnesses.
Okay, it was a nice presentation.
Thank you, ma'am.
I think what Dr. Pooja has rightly mentioned, probably you could actually follow up and see because you have anyways found out that there is
the
association. So probably I think it could really add up to your
sure, ma'am.
Research
yes,
also.
Thank you.
I think next is Dr. Sahana, who has to present FP1307. Yeah, are you ready?
Good afternoon, ma'am. Can you hear me?
Yeah, we can hear you.
Yes, ma'am, I'm ready. My PPT is on comparison of efficacy of diode laser versus ND Arc laser in treatment of retinopathy of prematurity. ROP was first described in 1942 by Terry and called it as retrolental fibroplasia and quickly became recognized as primary cause of childhood blindness throughout the developed world. It is a retinal disorder of low birth weight premature infants. It is significant cause of preventable blindness across both developed and developing countries. Globally, it is estimated to affect more than 50,000 infants annually. In India, every year, 500 children are estimated to become blind from ROP. Risk factors include anemia, sepsis, low vitamin E level, babies born before 32 weeks of gestational age, weighing less than 1,500 grams, oxygen use in premature infants, high arterial blood carbon dioxide, cyanosis, apnea, intraventricular hemorrhages, seizures, transfusion septicemia, in utero hypoxia, patent ductus arteriosus, and white race multiple births. Stages of ROP is divided into 5 stages. In stage 1, we see demarcation line. In stage 2, ridge, fibrovascular proliferation. Stage 4, foveal and extrafoveal, it is divided. That is partial RD. In stage 5, total RD. And associated factors like pre-plus disease and APROP also can be seen. Classification of ROP according to early treatment of retinopathy of prematurity is type 1 and type 2. In type 1, The treatment is recommended within 72 hours, whereas in type 2, observation can be done. Threshold ROP, zone 1 or zone 2 with stage 3, with plus disease. In stage 3, 5 contagious or 8 total clock hours to be involved. In our study, we studied this in a tertiary care center. It is a comparative study. Study period is 1.5 years. We screened for ROP in premature infants after 2 weeks of their birth date. Detailed history was documented. Ocular examination like anterior segment fundoscopy was performed. Diagnosed ROP according to ICROP. Laser indirect coagulation was performed according to ETROP guidelines. Here we are treating right eye of the baby by diode laser and left eye of the same baby with Nd:YAG laser. RETCam images were taken pre and post laser therapy. They were followed up every week until ROP regresses and vascularization is complete in zone 3. Also, after 1 month and 6 months, add-on laser were performed whenever required. We looked for signs of regression and complication. Demographic details, total baby were 30, among which 12 were female and 18 were male. Sepsis was, risk factors like sepsis was also taken into account. And add-on laser, like how many sittings was required for a particular number of babies who required first add-on laser, second add-on laser, and third add-on laser were also taken into account. Plus disease were also documented, APROP, and type of laser like red eye for red laser for right eye and green laser for left eye, with number of mean spot like 2120 spots in right eye and 2347 spot in left eye, where p-value was not significant. So in our result, babies with mean gestational age 28.6 weeks, mean birth weight 1.3 kg, where 76.7% was diagnosed with either zone 1 or zone 2, stage 3, 66.7% with type 1 pre-threshold, and 10% with APROP. Mean laser spot were 2120 in right eye and 2357 in left eye. 50.5% of right eye and 50.7% showed regression at first sitting only, and 56.6%, 20%, and 6.6% of eye required more like second, third, and fourth add-on respectively. Stage 2 or 3 babies required 2 to 3 times of laser therapy, where 66% of stages with ROP required 4 lasers. Again, right eye regression, left eye regression, how many weeks it regressed in period like flattening of region, vascularization, posterior torti. Hello, ma'am.
Yeah, your
Can you hear me, ma'am?
Your presentation not seen.
Now, ma'am.
No.
Can you see my presentation now?
No.
No.
Is it the timer? Is something related to the time?
1 second. Can you see now, ma'am?
Yeah.
Yeah.
Where did I stop, ma'am? I don't know. Like
You were with the results, I guess. Just go back to one slide to go back.
hello, ma'am. Can you
Yes.
see the?
Yes.
Okay.
I think you had finished this. You were about to go to the next slide.
Okay. So in our study, conclusion was like duration of rate of regression in right eye, which was treated by Nd:YAG laser, was almost same as that of left eye, which was treated by diode. And signs of regression like decreased congestion, posterior pole tortuosity, flattening of elevated edges, vascularization into zone 3 or 2,
You have I think your voice is breaking a lot.
Fibrovascular proliferation and failure to progress to next stage was observed at the same rate in both eye. Babies with stage 3 ROP with pre-plus or plus disease. Hello, can you hear me, ma'am?
Yes, but the voice is breaking on
Can
and
you
off.
hear me now?
Yes, better.
Dr. Sahana, continue, please.
Babies with stage 3 ROP with pre-plus or plus disease or AP or OP required longer. Yes, ma'am. Can you hear me now?
Yes, we can hear you. Continue.
Dr. Sahana, are you done with your presentation?
Not yet, ma'am. Can you hear me now?
Yeah.
Conclusion, ma'am. Duration of rate of regression was same as that of both eye, right eye and left eye. Signs of regression like congestion, posterior pole toxicity of vessel, flattening of elevated ridge, vascularization into zone 3 or 2, and disappearance of neovascularization, fibrovascular proliferation. Failure to progress into next stage was observed in same rate in both eye. Babies with stage 3 ROP with pre-plus or plus disease or AP or OP required longer duration to regress than stage 2 ROP, irrespective of the type of laser used. AP or OP required more add-on laser than stage 2 or 3, with same rate of regression in both eye. Hence, both lasers are equally effective in treatment of ROP. Diode has a longer wavelength with deeper penetration, causing it more painful compared to green laser. In developing countries, 532 nanometer green laser may be the only available laser in most centers. Well-known complications like cataract in green laser or retinal detachment in diode laser was not seen in any of our baby. Early treatment and screening of ROP with any laser is necessary in management of ROP to prevent sight-threatening complications. Thank you, ma'am.
Yeah, Dr. Sahana?
Yes, ma'am.
Yeah, you have not put anything in the discussion. I think in the conclusion slide, you have tried to summarize your results. And your study should be compared with that of other studies also. So that attempt you have not made.
Okay.
Otherwise, good presentation.
Okay.
I had just one question, Dr. Sahana. Did you treat any of them with anti-VEGF?
No, ma'am.
What was
only
the reason
laser.
ROP was treated with laser?
Ma'am, there was no indication of anti-VEGF as such, ma'am. Like according to ETROP, we treated with right eye or left eye. But if there was no regression or anything, we would have referred to other higher center, ma'am, for second opinion.
Okay.
Can we have Dr. Nagaratna presenting her free paper?
Thank you, ma'am.
Thank you.
Ma'am, can you see the screen, ma'am?
You haven't shared your screen.
Yeah.
No, ma'am.
No, we are not able to see. Yes.
Yeah.
Ma'am, my paper is on to determine the macular ganglion cell layer thickness changes in mild cognitive impairment by spectral domain OCT. Coming to the introduction, mild cognitive impairment is a syndrome in which the patient will have subjective and objective memory deficit or have impairment of other cognitive function other than memory. In MCI, patients who will lead a daily living and occupational activities will not be affected. And MCI represents a clinical condition in which the risk of developing dementia is increased and is accepted as a transitional stage between healthy and dementia. MCI is now recognized to be a risk factor for the development of Alzheimer's disease, and it is considered as a neurodegenerative condition which has multiple causes. The annual conversion rate from MCI to Alzheimer's disease has been reported as 10 to 15%. And mild cognitive impairment and other forms of dementia are a growing public health problems among elderly age people in developing countries. And there is no curative treatment for Alzheimer's disease, and now only available treatment is to postpone or prevent the progression. The association between disease of retina and the brain is based on common development, and there are structural similarities between retina and the CNS neurons. The retinal ganglion cells also undergo same neurodegenerative changes affecting the nerve fibers, ultimately lead to the glial tissue formation. Optical coherence tomography is a non-invasive technique which uses low coherence interferometry to produce two-dimensional image. And here we used a spectral domain OCT to quantify ganglion cell inner flexiform layer thickness. The assessment of cognitive impairment is based on mini-mental state examination for literate patient and the Montreal Cognitive Assessment Scale for illiterate patient. So accordingly, we have divided 24 to 30, there is no cognitive impairment. 18 to, if the score is between 18 to 23, it is considered as mild cognitive impairment. If it is less than 18 or 17, we have considered as severe cognitive impairment. Coming to the objective, it is to determine the ganglion cell layer thickness changes in mild cognitive impairment by spectral domain OCT. Study material, coming to the materials and methods, study design was hospital-based prospective cross-sectional study, and the study period was from May 2020 to August 2021. And data we were collecting from patients attending the OPD psychiatry department at Victoria, and we have evaluated them into hospital. Sample size was 30. Inclusion criteria: elderly subjects with no cognitive impairment, elderly subjects with cognitive impairment, and patients willing to give the informed consent. Coming to the exclusion criteria: patients not willing to give informed consent, and coexistence of ocular pathology like high myopia, glaucoma, optic nerve pathology, retinal vascular disorders, media opacities like cataract, choroidal neovascularization, and etc. Coming to the methodology, we have taken. Ma'am, can you hear me?
Yes, yes.
Coming to the methodology, we have taken detailed history and detailed ocular examination like visual acuity and refraction, anti-segment using slit lamp, and intraocular pressure measurements by Perkins 80, and dilated for fundoscopy. And later we have done spectral domain OCT. In my study, we have included 30 patients of age between 65 plus or minus 7.1 years, and among male were 80%, female at 20%. This is the thickness of ganglion cell layer by sector in mild cognitive impairment. And coming to the discussion, in our study, we have evaluated 30 patients of 40 eyes, ganglion cell layer thickness using SD-OCT in patients with mild cognitive impairment. OCT showed significant thinning in GCA-APL layer, especially in superior temporal, that is 70.50 plus or minus 7.42, inferiorly 71.16 plus or minus 8.84, and inferior nasally 70.770 plus or minus 7.43, and the mean age was 65 plus or minus 7.1 years. As we all know, there is a developmental association between brain and retina and optic nerve. Embryologically, eye develops from extension so-called optic curve from diencephalon. The microvascular system shares common physiology, and there are structural similarity between retinal ganglion cells, CNS, and the fibers of optic nerve. The retinal ganglion cells also undergo same neurodegenerative process affecting the neurons. The rate of conversion to dementia is 1 to 2% per year in general population, 5 to 10% in patients with MCI, and up to 50% in patients with amnestic form of MCI. Hence, it is suggested that to carry out routine evaluation of retina with OCT in all patients more than 60 years, so that we can detect early neurodegenerative changes for the early management, so that we can prevent or delay the progression to dementia or Alzheimer's disease. Coming to the conclusion, GCA-APL layer showed significant thinning in inferior nasal, and superior temporal region. From this study, we can conclude that MCI patients were found to develop neurodegenerative changes in retina also. So with the help of OCT, we can evaluate the retina and detect early changes in retinal nerve fiber layer, and hence helps in early detection and management of neurodegenerative disorders. These are all my reference. Thank you.
Dr. Nagaratna?
Yes, ma'am.
So from your study, you want to do OCT in all above 60 years of age, is it?
Ma'am, it is good to do about 60 years, ma'am, because even healthy patients will have like healthy patients will also get dementia, ma'am. If we won't screen, if more than 60, it is better to screen, ma'am, as per my study.
Okay.
Dr. Nagaratna, after you have, suppose, after, I mean, you have found out that the GCIPL thickness varies and helps in early detection of neurodegenerative disorders. So probably patients who have been, who have the disease and who have been started on treatment. Now, have you done a serial, I mean, have you extended and done a serial follow-up of GCIPL and how does it
Ma'am,
alter?
I haven't done follow-up, ma'am, because mild cognitive impairment patients may also lead normal life, ma'am, like in the sense may not be progressed to dementia, ma'am. So it may take more than a years, ma'am, like 1 year, 2 year, 3 years. It may take time, ma'am, to develop dementia, ma'am.
Correct.
So
But then,
when if we detect early, ma'am, we can prevent the progression. Like we can advise patient to meditate, do yoga or healthy lifestyle, avoid smoking, like that, ma'am.
okay.
It's a nice way to scare people, right?
Ma'am?
No, just kidding. One thing I wanted to know, you took normal elderly individuals as well, isn't it? Did you
Yes, ma'am.
compare them with the patients with the MCI, and did you find any significance between the changes in GCIPL?
Yes, ma'am. Only mild cognitive impairment patient had the thinning of retina, ma'am. Thinning of GCIPL, ma'am.
Okay, so the normal elderly did not have.
I didn't get, ma'am.
And would it be advisable to do a peripapillary RNFL changes or only a GCIPL makes sense?
Only GCIPL, ma'am. Actually, when compared to RNFL, GCIPL is better biomarker for
condition.
Yes, ma'am.
Okay. Right. More to learn from that. Okay, thank you.
Thank you, ma'am.
And Dr. Rupashri, if you are ready with your free paper, can you please share your screen?
Ma'am, my screen is visible. I hope my screen is visible, ma'am.
Yes.
Okay. Good afternoon, all of you. My presentation today is regarding the conjunctival microbial flora analysis that we have done in patients with diabetic macular edema who underwent multiple intravitreal injections. Myself, Dr. Rupashri, I am the presenting author, and my co-author for the study is Dr. Rudresh, who is the microbiologist with me. The purpose of our study was to evaluate the conjunctival bacterial flora in patients with diabetic macular edema who were treated with multiple intravitreal anti-VEGF injections under antibiotic prophylaxis and their association with their HbA1, with the patient's HbA1c levels. This was a retrospective observational cohort study of the case records. We included 92 eyes of 79 patients with diabetes mellitus who had received 3 or more seeded intravitreal anti-VEGF injections for DME between May 2018 and January 2020 at ESI Medical College, Rajajinagar. These were patients who attended our retina clinic. The conjunctival swab cultures were taken from each eye prior to the injection and evaluated for microbial growth. And the cultured conjunctival bacterial flora was noted and analyzed to their systemic glycemic control. Patients with HbA1c more than 7 were considered as having uncontrolled diabetes. We included patients who were aged above 18 years and all of them who had received 3 or more consecutive intravitreal injections of anti-VEGF. We excluded all patients who had been injected with triamcinolone acetonide or patients who underwent recent ocular surgery in the past 6 months or patients who were on topical antibiotics or steroids for a longer duration, and also patients using contact lens 6 months prior to the study. All the patients underwent treatment after routine physical investigations and physician clearance for intravitreal injection. Thorough ocular examination was also done to rule out all the abnormalities in the eyelids and the conjunctiva. So the swab collection was done 2 days prior to the planned injection, and conjunctival swabs were taken from the eye to be treated. This was following a drop of topical anesthesia that was instilled in the injecting eye. 0.5% proparcaine ophthalmic solution was used, and care was taken particularly to minimize contact with the eyelids and the lid margin. The swabs were transported as early as possible to the microbiology laboratory, where they were plated on 5% sheep blood agar, croclet agar, and McConkey's agar. Growth was observed for a period of 48 hours, after which the microbiologist reviewed the agars and listed the number of positive and negative cultures. The intravitreal injections were done in the operating room by a single surgeon, and a standardized procedure was followed. All patients in the study had received topical moxifloxacin eye drops for a day prior to the injection and for 3 days after the injection. Statistical analysis was done using SPSS statistical software, and the value of less than 0.05 was considered statistically significant. The results that we noted, we included 92 eyes of 79 patients in the study, of which 66 patients had received injections in one eye, and 13 patients had bilateral injections during the study period. Among the patients, 54 were males, 25 were females. The average age of the patient was around 58 years, and the average number of injections that they had received before the start of the study was around 4. During the study period, 78 eyes received intravitreal ranibizumab, and 14 eyes were given intravitreal aflibercept injection. So this is a gross analysis of the conjunctival swab growth. 27 of the 92 eyes showed a positive microbial growth, and there was no growth noted in about 65 eyes out of the 92 eyes. The interesting thing to be noted is the swab growth. The predominant growth organism was coagulase negative staphylococcus, which was found in 15 out of 29 swabs. And more significant is to note that more than 10 eyes of the patients had HbA1c of a value more than 7 in patients who were growing coagulase negative staphylococcus. The other organisms that we found were diphtheroids and micrococci. To correlate between the positive microbial growth and the HbA1c levels, positive growth was noted in about 30% of our study population, and all of them had an average of HbA1c more than 7, which according to physician analysis as is understood as poor glycemic control. Though the statistical association was not very significant for us. Coming to the discussion, we all understand that evaluation of the conjunctival bacterial flora is used as an important surrogate marker of to assess the risk for postoperative endophthalmitis. According to VRSI guidelines, there are recommendations to use routine topical pre-procedure and post-procedure antibiotic prophylaxis for patients receiving intravitreal injections, patients with debilitating systemic illness and with poor lid hygiene. However, there's a recent survey published which says that most of the Indian retinal specialists show only about 60% of them using pre-procedure or pre-injection topical antibiotics, and nearly 90% of them are also using antibiotic prophylaxis following the intravitreal injection. In our study, we found that around 60% of the patients who had 30% of the patients who had received serial intravitreal injections and who were on and off on topical antibiotic prophylaxis still showed positive microbial culture growth in their conjunctiva, and they also recorded a mean higher HbA1c values. Another important thing to be noted was most of them had grown coagulase negative staphylococcus, and their mean HbA1c was much higher than the all the other organisms in the eyes of the patients that grew. We understand that there were certain limitations in our study because we need to cross-check this with a large prospective study, basically to look for the presence of any antibiotic resistance and the susceptibility patterns of the organisms that were isolated in our hospital population. To conclude, I would like to say that routine pre-intravitreal injection topical antibiotic prophylaxis will still be beneficial, especially in patients who have poor glycemic status and those who are undergoing serial intravitreal injections. And we need to do a large cross-sectional study or a prospective study to collaborate our data. Thank you so much.
Yeah, Dr. Rupashri?
Yes, ma'am.
Yeah, in your study also you have used both pre and post antibiotic drops, right? So that
Yes,
could have interfered with your analysis.
Yes, ma'am. These were patients who were already on the same protocol prior to the onset of study. They were prior to the injection and after the injection also they were put on topical moxifloxacin eye drops. So we have particularly taken a group of patients who have been for the past 3 or 4 months received serial injections and been on and off on antibiotic prophylaxis, and despite that just a routine conjunctival swab showed certain growth. So our intention was to understand whether the positive microbial growth is it in relation to their poor immunity, or like we could not understand whether it was because of antibiotic resistance. So we would like to follow it up with the prospective study to see if there is also an antibiotic resistance developing in our hospital population, ma'am.
Yeah, probably that would help.
Yes, ma'am.
How many days of post-injection did you use the antibiotic drops? How many days?
3 days. 3 days, ma'am. 3 days.
And pre-injection 1 day before or
1
the
day prior.
on the day of?
No, 1 day prior, ma'am.
Okay. Maybe, I mean, just a thought, probably in the interval period between the two injections, there may be maybe a conjunctival swab or something really could get us some kind of an insight into this also. Probably. That's what I was
Yes, ma'am. Yes, ma'am. Yes, ma'am. That's our intention to continue it as a prospective study, like I said before, to see whether it is antibiotic resistance or it is really related to the patient's immune status.
Right. Dr. Sanjay, anything do you have to comment on this?
One thing, I think it is a very good study. It's something we need to know because the number of injections that have been being used is much more on the rise. The only thing is, did you find any difference post-injection? Any reactions or any sterile vitritis or anything? With,
no, ma'am. No reactions. No reactions, ma'am.
Yeah. So we need to find out the significance of this clinical management.
Because once the patients actually had some growth, we have not gone ahead with the injections. That is the reason we have collected the swabs 2 days prior. So we get the report on the day of the injection. If there is a positive growth, we start them on antibiotics, observe for a week, repeat culture. Okay. Repeat the next week. If it is only if it shows if it's sterile, then the procedure is we continue with the injection.
Okay.
Yeah, and also I think comparative study, like what you said, like what Dr. Sandhya was commenting, a kind of reaction between if you have used, I mean, anyway, if you have a growth on the conjunctival swab, you did not proceed with the injection.
We did not.
You gave the antibiotic drops for a week, right? And then you started.
Yes, ma'am. Yes, ma'am. We gave for a week. We repeated the conjunctival swab. Only if it showed no growth, the next week the patient underwent injection.
Okay. I think that was a very good presentation, Dr. Ramesh.
Thank you, ma'am.
Dr. Shamanta?
Yes, ma'am.
Yeah. Are you ready with your presentation?
Yes, ma'am. I'll share the screen, ma'am. Yes. Am I visible, ma'am?
Yes.
Yeah, you can start.
Can I start, ma'am? Okay. Good afternoon, everyone. I'm Dr. Shamanta. I'll be presenting on variable ocular presentation seen in miliary tuberculosis. My chief author is Dr. Hemalata, ma'am. Coming to the introduction, miliary tuberculosis accounts for almost 2% of all the new cases of tuberculosis, and 20% of them may be fatal form, and spread occurs through hematogenous dissemination. The chest radiograph showing the miliary tubercle is a classical hallmark, and miliary tuberculosis can be both pulmonary and extrapulmonary. Coming to our first case, a 23-year-old female presented to us with a sudden loss of vision in right eye since 2 weeks, which was sudden in onset, painless, and non-progressive in nature. And recently, she was being diagnosed as miliary tuberculosis 1 month back, and she was started on ATT. She was also treated for complications associated with it, like anemia, altered blood electrolytes, and deranged LFT, and low oxygen saturation in the blood, during which patient gives us a history that she had multiple episodes of vomiting, and also her CTPA showed pulmonary artery thrombosis. Coming to the ocular examination, her best corrected visual acuity in the right eye was 660 and left eye was 66, and rest of the anti-segment examination was normal. And this is coming to the fundus evaluation. This is the fundus photograph of the patient when she OCT image. Coming to the treatment, she underwent Yaag laser hyaloidotomy, during which patient improved to 6'9", and these are the serial photographs of fundus and OCT when she in her follow-up. Ma'am, can you hear me, ma'am? Hello.
Yes.
Yes. Yeah, continue.
Yeah, ma'am. This is the serial photographs of fundus and OCT when she presented, and the 6'9" was vision was stable and maintained in her regular follow-ups. And she was also treated systemically. And the possibility of subhyaloid hemorrhage in our case may be due to Valsalva manure because of history what she gives of severe coughing and vomiting, and also can be precipitated by multiple factors like deranged LFT and also anemia and altered blood parameters. Coming to our second case, a 26-year-old male came for the regular ophthalmic examination as he was referred by a pulmonologist as he was diagnosed with miliary tuberculosis recently for just an ophthalmic screening. His BCVA was 6.6 in both eyes, and rest of other anterior segment examination were normal, and anterior chamber showed no signs of uveitis. This is the fundus photograph of the patient. In left eye. We can see along the inferior arcade a whitish to yellow lesion, which was a choroidal tubercle, and he was also, and the investigations which confirmed tubercular etiology was that he was other major organs also. He had miliary opacities like the lungs, liver, and periportal and paraaortic lymph nodes. And USG guided FNAC was done with the same, and it was diagnosed as tubercular etiology. This was the lymph node, and he was put on ATT treatment. And with only systemic treatment, there was significant reduction in the choroid tubercle. As we see, this is when patient presented to us after 1 month of follow-up. We can see the reduction in size of the choroid tubercle in fundus and OCT picture. Coming to the discussion, acute miliary tuberculosis results from mycobacterial tuberculosis bacteremia in persons whom resistance is low. And here we see a male preponderance and a bimodal presentation as said by the other studies. And common mode of ocular presentation which we see in tuberculosis patients are panuveitis, vasculitis, nodules and tubercles as we saw in our second case, and also multifocal serpiginous like choroidopathy. And as we see in the first case, various altered parameters may cause varied presentations like SHH as in the first case, and has to be kept in mind while treating miliary tuberculosis. Thus, we conclude that all patients of miliary tuberculosis should undergo fundus evaluation once the patient is diagnosed with the disease. And various changes in the fundus not only will help us to know the severity, but also we can alert us on the associated systemic complication which would have set in due to miliary tuberculosis. And also a long-term periodic follow-up has to be emphasized in these patients. Thank you, ma'am. Hello.
Dr. Shamanta?
Yeah, ma'am.
Yeah, so all the 2 young patients were immunocompetent?
Yes, ma'am. Both were immunocompetent.
Okay. Yeah, nice documentation of the study.
Thank you, ma'am.
Yeah, Dr. Shamanta, that was a nice presentation. Yeah,
Thank
probably maybe we can just proceed, and you can actually continue your this one, and probably we may arrive at much definitive conclusions and implications, I guess.
Yeah, ma'am. Thank you, ma'am. But yeah, ma'am, there was no any other present case report or anything which was presented as subhyaloid hemorrhage in miliary tuberculosis.
Correct. That's what. That's a very good documentation of your findings.
Thank you, ma'am. Ma'am, can I stop sharing, ma'am?
Yeah. Thank you so much.
Thank you, ma'am.
Dr. Shima, are you ready?
Good afternoon, ma'am. Myself, Dr. Shima Mariam, ophthalmology resident, presenting a paper on bilateral exudative retinal detachment secondary to malignant hypertension. So the hypertension has been identified as a major cause of morbidity and mortality across the world. It affects about 1 billion people worldwide. About half of them remain unaware of their hypertensive status. Malignant hypertension is a sudden increase in blood pressure more than 200 with 120 diastolic millimeter of mercury. The ocular damage due to accelerated hypertension or malignant hypertension is a well-established phenomenon. Vascular narrowing is the primary response of the retinal arteries to hypertension. The presence of macular serous retinal detachment has been reported to be a marker of malignant hypertension. So, coming to the case report of 29-year-old female presented with 1-day history of sudden onset, painless loss of vision in both eyes. The loss of vision is associated with headache. She is a known case of hypertensive for 6 months on irregular medication. Coming to the ocular examination, the anterior segment of the right eye, the vision of the right eye was hand movements with no pinhole improvement. The left eye examination, the vision was counting fingers of 2 meters with no pinhole improvement. Other anterior segment examination of the right eye was normal, except for the pupil, which showed relative afferent pupillary defect. But the ocular findings of the left eye was normal. The intraocular pressure was recorded and it was 14 millimeter mercury in right eye and 15 millimeter of mercury in left eye. Coming to the fundus examination, on distant direct ophthalmoscopy, both eyes showed media, hazy and grayish reflex. In indirect ophthalmoscopy showed bilateral disc swelling with inferior retinal detachment extending from 4 to 7 clock hours with flame-shaped hemorrhages and cotton wool spots over the blood vessels with arteriovenous crossings with dull foveal reflex. OCT showed bilateral exudative detachment of the sensory retina. On systemic examination, it was found to be blood pressure of 200 with 120 diastolic millimeter mercury. The patient was referred to physician for the management of hypertension. Physician diagnosed that patient have acute renal failure with a laboratory investigation of urea 101 milligram per deciliter and creatinine of 11.6 milligram per deciliter requiring urgent dialysis. Patient underwent dialysis. On follow-up, after 1 month, the blood pressure was in normal limits. The visual acuity improved to 618 both eyes with the exudative retinal detachment in both eyes resolved except with few residual hemorrhages. So coming to the discussion part, it is necessary to obtain a fundus examination in any patient with elevated blood pressure and concomitant vision complaints. Therefore, screening hypertensive patients involves close collaboration between internist and ophthalmologist. Antihypertensive is the first line of treatment, but if the exudative retinal detachment is not resolved and the retinal detachment is chronic and bullous, surgical intervention can be planned to drain the fluid. So, accelerated hypertension can precipitate bilateral exudative retinal detachment. Bilateral exudative retinal detachment is a catastrophic event which results in devastating vision loss within very short time span. Timely intervention may save the vision loss and the renal failure. Thank you, ma'am.
Yeah, thank you, Dr. Shima, for a nice presentation on the ocular features in malignant hypertension. Indeed, all of us do receive references for looking for fundus examination in patients with hypertensive retinopathy, and definitely we need to be very cautious when we are examining a patient with malignant hypertension.
Yes,
and also very important that most of the times it's like masterly inactivity from the side of a consultant ophthalmologist.
Yes, ma'am.
Until unless most of the times it's just a systemic derangement causing a lot of inflammation, causing a lot of derangements in the blood-ocular barrier. So
Yes,
therefore, to investigate and then to properly refer to the patient and to have a correct differential diagnosis matters a lot in such cases.
Yes, ma'am.
Any inputs from Dr. Sandhya and Dr. Pooja?
I guess it's more important that when a patient is not diagnosed hypertensive, it's important. Most of the times the patient comes to us first, and we have to keep in mind the differential of malignant hypertension, just a measurement of a blood pressure, which gives an insight into complete disease. So it's interesting, especially because the renal parameters were so abnormal that early treatment was essential. So thank you, Dr. Shima. That's it.
Thank you. Let us move to Dr. Soumya. Dr. Soumya, you please share your screen.
Good afternoon, everyone. Today I'll be talking about the estimation of central foveal thickness in patients of post-fever retinitis in a tertiary healthcare center. Chief author for my topic is Dr. Shilpa ma'am. Post-fever retinitis is an infectious or para-infectious condition with retinal manifestations following the systemic febrile illness, which may be caused by bacteria, viruses, or protozoa. It's also called as post-fever uveoretinal sequelae occurring 2 to 4 weeks after the febrile episode. It may also be called as epidemic retinitis due to its seasonal variation in correlation with outbreaks such as rickettsia, dengue, or chikungunya. Patients present with sudden onset painless diminution of vision associated with floaters, flashes, visual field defects, and central blackouts. Posterior segment manifestations include focal and multifocal patches of retinitis, predominantly in the posterior cone, macular edema, and localized retinal vessel wall bleeding, tortuosity, and perivascular sheathing. Organisms causing the condition include viruses such as dengue, West Nile fever, chikungunya, Zika, Ebola, influenza, and coronavirus. Bacteria such as rickettsia and typhoid. Tomography is used in my study to assess the central foveal thickness and to compare the macular edema. Purpose of the study is to assess the resolution of patients of post-fever retinitis following treatment with respect to various etiologies, and to assess the duration of resolution of macular edema in various causes. This is a hospital-based prospective study conducted between May and July 2021. History was taken for all the patients, and all of them underwent routine ophthalmic evaluation and macular pube spectral domain OCT for the assessment of central foveal thickness. Parameters are assessed follow-up of 1 week and 1 month. Irrespective of the known etiology,
Dr. Soumya, we can't see your screen.
Should we continue with the next presenter, ma'am? I think she has connectivity issues.
Yeah, I think we can ask Dr. Sunanda to present her free paper. Meanwhile, she can get ready with the paper, I guess.
Hello, ma'am. Am I audible?
Yeah, Dr. Sunanda.
Hi,
Please
ma'am.
share your screen.
Good afternoon, everyone. Today, my topic is Eyes Are Never Quiet, Choroidal Tuberculosis with Tubercular Meningitis, a case report. Coming to the introduction, tuberculosis represents a global health challenge. According to the WHO, it is one of the top 10 causes of death worldwide, when 1/3 of world's population infected with it. Ocular TB is a rare extrapulmonary form of the disease, and it represents a major diagnostic and therapeutic challenge due to its heterogeneous clinical manifestations, mixed ocular tissue involvement, lack of diagnostic criteria and gold standard tests, and a lack of international agreement on the therapeutic approach. Prevalence of TB uveitis is 0.2% to 2.7% in regions where TB is not endemic, including USA, Europe, or Japan, to 5.6% to 10.5% in highly endemic areas such as India. A 19-year-old patient presented to our OPD with complaints of fever, insidious, progressive, high grade with evening rise of temperature. She also complained of diminution of vision in both the eyes, insidious, progressive, painless. She had headaches since 3 days, which was associated with vomiting, which was non-projectile, non-bilious, along with generalized weakness. She had been admitted in the medicine department for the same. She had history of cough since 15 days and history of loss of weight. On general physical examination, neck rigidity was present, and auscultation of chest revealed bilateral coarse crepitations present at the base of the lungs. On ophthalmic evaluation, her best corrected visual acuity was 6/6 with minus 0.5 sphere in both the eyes, and anterior segment was absolutely normal. There was no AC cells or vitritis. Coming to the fundus picture, right eye shows 3 yellowish creamy subretinal lesions with indistinct margins suggestive of choroidal tubercles. They have approximately half this diameter, one present at the edge of the superior temporal arcade, one at inferior temporal arcade, and one present at about 1 disc diameter from the optic disc. Similar lesions were seen in the left eye, with the one present at the superior temporal arcade and another approximately 1 to 2 disc diameter at the inferior temporal arcade. This is a right eye OCT, and this HD OCT is through a lesion, which showed hyperreflected lesion with diffuse borders involving the deeper layers of the retina, or with alteration of the layers of the outer retina. There we can see the bulging of the RP and Brooks complex. Similar picture was seen in her left eye OCT along with the small amount of SRF fluid. We further investigated the case, and her CBC was absolutely normal except her hemoglobin, which was 9.6. Peripheral smear showed microcytic hypochromic anemia. RFT, LFT, serum electrolytes were within normal limits. Her serology, HIV, HPCG, VDRL, COVID, all was negative. Chest X-ray, small nodular lesions in both lung fields were seen, suggestive of miliary tuberculosis. CBNAT was done, MTB was detected, which was rifampicin indeterminate. 2D echo, USG, CT brain were absolutely normal. Lumbar puncture was done. Opening pressures were 30 centimeter of water. CSF analysis showed normal composition with the increase in neutrophils. She was diagnosed with both eyes having choroiditis secondary to tuberculosis with tubercular meningitis, and was started on anti-tubercular treatment category 1, along with pyridoxine, injection mannitol, and fluids. After treatment, the case was followed up, and we can see her lesions to be resolving. This is her right eye, and compared to the previous picture, this is her left eye, which shows fading of the lesions. Coming to the discussion, tuberculosis is a serious infectious disease primarily affecting the lungs. TB is caused by acid-fast bacteria belonging to the Mycobacterium tuberculosis complex. Ocular TB being the vision-threatening variant. Posterior segment can be involved in the forms of vitritis, pars planitis, chorioretinitis, choroiditis, or optic neuritis. In certain cases, ocular TB helps physician to make appropriate early diagnosis with the help of an ophthalmologist and to decide further treatment. Ocular TB is a little bit more difficult to diagnose than pulmonary disease. A definitive diagnosis requires an interspecialty interaction and a high clinical suspicion. To conclude, it is a rare extrapulmonary manifestation of tuberculosis infection. This case highlights that a seemingly innocuous eye involvement can also be associated with significant systemic tuberculosis. Early diagnosis and timely intervention helps in preventing the occurrence of vision-threatening complications in case of ocular TB. Ophthalmic evaluation in such cases are essential as a guide for specific investigations and decision-making in starting anti-tubercular treatment, as choroidal tubercles can also be the first sign of extrapulmonary tuberculosis. These are my references. Thank you.
Yeah, Dr. Sunanda, that was a nice documentation of the clinical features of patient with tubercular meningitis. And I think in the case, all of us are pretty aware that tuberculosis can manifest in a variety of, can have a variety of manifestations, both typical as well as atypical. We have seen that many cases of uveitis, unless and proved otherwise, that too, especially with Indian data, you always have to rule out tuberculosis. Yeah, that was a nice clinical presentation for that. Thank you, Dr. Sunanda.
Thank you, ma'am. Thank you.
Just one thing, Dr. Sunanda, you said the patient presented with bilateral blurring of vision, isn't it? And then you said the vision was recorded 6, 6, and 6. That was not correlating for me. Are you there still?
Dr. Sunanda?
Okay. And we'll go on to the next presenter.
Dr. Soumya, do you want to present now?
Sorry, ma'am.
Yes, ma'am.
Dr. Sunanda, Dr. Sandhya was asking a question.
Yes, ma'am. Yes, ma'am.
You said the patient presented with bilateral vision loss, isn't it? Progressive.
Yes, ma'am.
But the vision was recorded as 6, 6, and 6.
Yes, ma'am. She had a good vision, ma'am, with absolutely normal anterior segment.
What do you think? What was the reason for her vision loss? Blurring? There was no vitritis. There was no anterochamber reaction.
Ma'am, she was just saying that she was having diminution of vision, but as such, her visual acuity was 6/6, ma'am.
Okay. The second thing is you said TB meningitis. The CT brain was normal. The CSF analysis was normal. Is it expected with the tubercular meningitis?
Ma'am, opening pressures were high, and there was like some increase in neutrophils and
M goes against it, isn't it?
and also she had some features of meningitis on clinically, ma'am. Like she had neck rigidity, it was present, ma'am, and vomiting she had along with headache, ma'am. So
Correct. Yeah, disseminated is yes, because she had a medullary tuberculosis in the lungs, along with eye involvement. So category 1 is given for how many months? That was my last question. It's my information. Yeah.
Usually, ma'am, it is given from 6 to 9 months, ma'am.
How do we decide? 9 months?
9 months, ma'am, if the lesions are not resolving, ma'am, and it is associated with other systemic features, ma'am.
Okay. So this patient received 6 months or 9 months?
Ma'am, she's still on treatment. She has not yet completed, ma'am.
Okay, fine. Thank you, Dr.
Yes, ma'am. Thank you, ma'am.
Thank you. We can move on to the next presenter, please. Dr. Soumya?
Hello, ma'am. Am I audible?
Yes.
Shall I share the screen, ma'am?
Yes, please.
Good afternoon, everyone. Today I'll be talking about the estimation of central foveal thickness in patients of post-fever retinitis in a tertiary healthcare center. My chief author is Dr. Shilpa, ma'am. Post-fever retinitis is an infectious or para-infectious condition with retinal manifestations following a systemic febrile illness, which may be caused by bacteria, viruses, or protozoa. It's also called as post-fever uveoretinal sequel, occurring 2 to 4 weeks after the febrile episode. It may also be called as epidemic retinitis due to its seasonal variation and correlation with outbreaks such as rickettsia, dengue, or chikungunya. Patients present with sudden onset painless diminution of vision associated with floaters, flashes, visual field defects, and central blackouts. Posterior segment manifestations include focal and multifocal patches of retinitis, predominantly in the posterior pole. There may be optic nerve involvement, macular serous detachment, macular edema, localized retinal vessel wall beading, tortuosity, and perivascular sheathing. Organisms causing the condition include viruses such as dengue, West Nile fever, chikungunya, Zika, Ebola, influenza, and coronavirus, bacteria such as rickettsia, typhoid, protozoa such as malaria. Here we use macular cube optical coherence tomography to assess the central foveal thickness and to compare the macular edema. The purpose of my study is to assess the resolution of macular edema in patients of post-fever retinitis following treatment with respect to various etiologies, and to assess the duration of resolution of macular edema in various causes. This is a hospital-based prospective study done between May and July 2021. History was taken for all patients, and all of them underwent macular cube spectral domain OCT for the assessment of central foveal thickness. All the parameters were assessed during the follow-up period of 1 week and 1 month. Irrespective of the known etiologies, all the patients were started on capsule doxycycline 100 mg BD for 21 days empirically, and tablet prednisolone acetate 1 mg per kg body weight with tapering dose after physician clearance. We included patients of the age group 20 to 60 years with history of fever in the past 1 month with complaints of diminution of vision. A total of 41 eyes of 25 patients were evaluated and macular cube OCT was done. 17, that is 68% of these patients were male and 8 were female. 9, that is 36% of these patients were unilateral. 14 were bilateral, and 2 patients were unilateral at presentation but progressed to bilaterality. All of these patients gave history of fever 2 to 4 weeks before the onset of ocular symptoms. Visual acuity of these patients ranged from counting fingers at 1 meter to 6/12 at the time of presentation. The purpose of the study was explained to the patients and the informed consent was taken from them. Etiology of 18, that is 72% of the patients, was unknown. 5 patients gave bacterial etiology such as typhoid was seen in 3 patients, oral abscess was seen in 1 patient, and ASOM was in 1 patient. 2 patients gave viral etiology, that is chikungunya was seen in 1 patient, chickenpox was in 1 patient. Among the various etiologies, 1 patient with typhoid was unilateral at presentation but progressed to bilaterality even after 1 week of treatment, but it subsided during the subsequent follow-up visits. After 1 week of treatment, out of the 41 eyes, 36 eyes, that is 87.80%, showed a reduction of central foveal thickness of up to 400 micron, and 1 showed reduction of up to 800 micron. Whereas 4 eyes, that is about 9.76%, showed an increase in the central foveal thickness of up to 400 micron, which subsided during the subsequent follow-up at 1 month. After 1 month of treatment, 36 eyes, that is 87.80, showed a reduction in central foveal thickness of up to 400 micron, and 4 patients showed reduction of up to 800 micron. whereas one eye showed an increase in the central foveal thickness of up to 400 micron, but again it subsided during the subsequent follow-up at 3 months. One-way ANOVA test was done and the p-value was found to be significant. One patient with chickenpox showed the highest reduction in central foveal thickness after 1 month of treatment. Initially, it was 1424 micron and it reduced to 251 at the end of the course. Average central foveal thickness was found to be 495.53 micron at the time of presentation. Highest was seen in chickenpox, as I said earlier, and lowest was 221 micron with no known etiology. There was an improvement of 612 to 66 in the visual acuity after 1 month of treatment in most of the patients. Even in the remaining patients, there was improvement in the subsequent follow-up at 3 months. Most patients improved to normal central foveal thickness within 1 month of treatment. That is 240.26 micron, with highest being 404 and lowest being 99 micron. When we compared among various etiologies, there was no correlation between the central foveal thickness. Here's an image showing the reduction in the central foveal thickness at the time of presentation after 1 week of treatment at 1 month of treatment. In a study conducted by Deepak Sundar M. et al., there was characteristic fundus and OCT findings were described, and combination treatment with oral steroids and oral doxycycline were found to show improvement in BCVA and central foveal thickness. In a study conducted by Anand Khetri et al., imaging modalities like OCT, OCTA, and deep range imaging were shown to play important roles in monitoring and progression of the disease, as well as the response to the treatment. In a study conducted by Nageshwar Rao et al., OCT was useful in assessing the resolution of neuroretinitis, macular edema, and serous detachment during follow-up. In a study conducted by Srilata Vishwanath, Kalpana Badami et al., it was noticed that the hyperreflectivity on OCT decreased after treatment in case of post-fever retinitis, suggesting resolution. So ours is a prospective study conducted in a tertiary healthcare center. We evaluated 41 eyes of 25 patients, and central foveal thickness was assessed before and after treatment with oral doxycycline and oral steroids. In our study, we assessed the changes in the central foveal thickness on OCT and thus the resolution of macular edema upon starting the treatment. An assessment of central foveal thickness among various etiologies was done, but was not found to be noteworthy. So to conclude, post-fever retinitis can occur following a febrile illness caused by bacteria, viruses, or protozoa. Macular edema is one of the posterior segment manifestations and is found to be evident in all our cases. Spectral domain OCT, macular cube, was used to assess the progression of the edema. Treatment with systemic broad-spectrum antibiotics and steroids will bring resolution of macular edema in these patients as seen in our study. Thank you.
Dr. Soumya?
Yes,
Dr.
ma'am.
Soumya?
Yes, ma'am.
Hello? Can you hear me?
Am I audible, ma'am? Yes, ma'am.
Yeah, can you hear me?
Yes, ma'am. Yes, ma'am.
Okay. For how many weeks did you give doxycycline in your study?
21 days, ma'am.
Only for 3 weeks?
Yes, ma'am.
Okay. And what was the best corrected visual acuity on follow-up?
Most patients had 612 to 69, ma'am, on normal vision, uncorrected visual acuity. Best corrected was 6966 in most of the patients, provided they did not have cataract.
Okay.
Okay, thank you, Dr. Soumya, for a very apt presentation.
I have just one question. Do you include HIV testing for all of these patients before you start oral steroids? Do you do
We conduct all routine investigations with serology, HIV, HBsAg, and HCV. Also, we do bone toe, ma'am, and chest X-ray. Then we get physician clearance before starting them on steroids, ma'am.
Okay.
Any role of antiviral, systemic antivirals in these cases?
Especially chickenpox?
Start, ma'am. We had given only doxycycline.
Okay.
What is the doxycycline aimed at? Which particular organism? Does it cover, I mean, most of the other that we are expecting?
Yes, ma'am. Yes, ma'am.
Okay. Because there are many studies who give only oral steroids without any antibiotic cover. So the idea of trying to treat these patients would be to try and get an idea of what particular organism is the causative agent. So accordingly, maybe we could try to reduce the systemic antibiotics or add antivirals if required. Oral steroids is the mainstay of treatment. Some people even treat intravitreal or poster subtenance nowadays. And ITF, but that is mainly for macular ischemia, if you have associated. Since none of your patients have had that bad condition, that is one, okay, that's fine. But the other thing is, I wanted to know if, central foveal thickness is important only when you have a lesion which is closer to the macula and it is, affecting the macular edema, you can look at. But the resolution of the lesions would be another parameter that you could look at along with the central foveal thickness.
Yes, ma'am. Okay.
Yes, that would
Did you add any topical non-steroidal anti-inflammatory also? Topical drops?
Yes, Nepafenac we give, ma'am.
Okay.
There were studies which have conducted only for doxycycline and only steroids as well, and as a comparative study as well, ma'am. But here doxycycline we give because it covers most of the organism, most of the bacterial organisms, gram positive, negative, aerobic, anaerobic, both, ma'am. So we give it as empirical treatment, ma'am.
Okay.
Okay, thank you. Dr. Vinay, can you just share your screen?
Yeah. Good afternoon, everyone. I'm presenting a paper like in the section of medical retina, management of subhyaloid hemorrhage with ND-YAG hyalotomy. Myself, Dr. Vinay Kumar, and co-author is Professor Dr. Venkatagowda HD. So there's no financial interest. Pre-retinal subhyaloid hemorrhage is caused by various causes, most common being valsalva retinopathy, and it can also occur following trauma, proliferative diabetic retinopathy, retinal vascular occlusions, retinal macroaneurysms, and Terson syndrome, and including Eales disease. Subhyaloid hemorrhage can also be associated with subialum bleed. Spontaneous resorption of the hemorrhage occurs in few cases, but may take up to 1 to 2 months. But persistent heme may lead to formation of the pre-retinal membranes and traction, and hence early treatment is advocated. Treatment options include ND-YAG hyalotomy, though say few complications like epiretinal membrane formation and macular holes are reported. Other options are surgical removal by pars plana vitrectomy and intravitreal injections of TPA and the gas. Our aim is to study the effect of ND-YAG hyalotomy in patients with subhyaloid hemorrhage in various retinal diseases. Ours was a retrospective study with patients with pre-retinal subhyaloid hemorrhage treated with YAG hyalotomy were included. Sample size was 12 eyes. All patients underwent best-corrected visual acuity, slit lamp examination, dilated fundus examination, fundus photo, and OCT. ND-YAG hyalotomy with patient's consent, and above tests were repeated after the ND-YAG laser. We used Zeiss Visualance YAG-3 machine with an ocular mainstay focal lens, anterior focus, single spot. Power was titrated, usually between 4 to 6 millijoules. Coming to the results, 12 eyes of 12 patients were examined. 10 were male and 2 were female. Mean age was 48 years and the mean duration of symptoms was 14 days. ND-YAG hyalotomy was successful in around 91.66% and unsuccessful in 8.4%. It was a case of proliferative diabetic retinopathy where pars plana vitrectomy was done. The distribution of the cases based on the etiology, like the most common being like valsalva retinopathy, which compromises 41.6%, followed by proliferative diabetic retinopathy, trauma, branch retinal vein occlusion, and retinal macroaneurysm. This is a chart like showing patient characteristics where we can see the best corrected visual acuity improved in all the patients at 6 weeks, except for the PDR patient where the patient needed like vitrectomy. So these are the fundus pictures in each of the etiological groups. So coming to the first one, like is the valsalva retinopathy. It is the before and after the ND-YAG hyalotomy. And after the laser in the OCT, we can see a sub-ILM pocket or sub-ILM bursa, where since the ILM is taut, the collapse of the ILM may take around a few months to years. So valsalva is usually associated with both sub-eyelid and sub-ILM bleed. And proliferative diabetes, this is a case of proliferative diabetic retinopathy, where we can see a neovascularization of the disc along with subhyaloid hemorrhage. Initially, we did like 3 sittings of panretinal photocoagulations. On the day of 3rd sitting, we did a YAG hyalotomy also, where the subhyaloid hemorrhage was drained. Usually, like these cases, like after the panretinal photocoagulation, we advise the patient for the surgery, like at least after waiting for a month or 6 weeks. But before advising the surgery, like definitely we can attempt for a YAG hyalotomy where the pars plana vitrectomy can be avoided. This is a case of a post-traumatic case, like where YAG hyalotomy drained the subhyaloid bleed. So usually in post-traumatic cases, like we can see hemorrhage in all the layers, like subhyaloid heme, like sub-ILM heme or subretinal bleed. in the last picture, like you can see a pocket of sub-ILM bleed after once the subhyaloid heme is drained, like the pocket of sub-ILM bleed is still present. And the fovea was clear and the vision was 6-9 at 6 weeks. So this is a case of branch retinal vein occlusion, where the upper and right photographs, you can see a sclerosed vessel with a neovascularization elsewhere in the superior quadrant. First, we did a sectoral PRP. So on the same day, like we did a YAG hyalotomy to drain the subhyaloid hemorrhage. So, and the last is the retinal artery macroaneurysms, where in the fundus fluorescent angiography, we can see a hyperfluorescence in the macular branch of retinal artery. So since the lower edge of the heme was very close to the fovea, we did the YAG hyalotomy in the temporal edge, and we asked the patient to lie down temporally. Though the subhyaloid heme cleared, but since there was a scar at the fovea, the vision was 6/60 at the end of 6 weeks. So coming to the discussion, though there are many studies like quoting use of ND hyalotomy in Valsalva retinopathy or Terson syndrome. So Rennie et al. And Katka et al., like they involved all the retinal conditions, including proliferative diabetic retinopathy, Eales disease, and retinal vascular occlusions and retinal artery macroaneurysms. The cause of the unsuccessful laser being, like in our case, as it was a proliferative diabetic retinopathy, and with the Katka et al., it was Eales disease and retinal vascular occlusion. So see, looking at the diseases, like the proliferative nature and the thick hyaloid in these cases, like may prevent may be difficult for the YAG opening in the posterior hyaloid. These cases may need vitrectomy. Laser drainage was introduced in 1973, and the studies have been shown that Valsalva retinopathy using YAG hyalotomy is safe, and usually visual recovery is in 100% of the eyes treated with YAG laser. So coming to the conclusion, ND YAG laser hyalotomy is a safe, inexpensive, and effective procedure. It achieves rapid resolution of premacular subhyaloid hemorrhage with restoration of the visual function, preventing the need for vitreoretinal surgery. Though the final visual prognosis depends on the underlying cause of the subhyaloid hemorrhage and accompanying the macular changes. At least in few of the cases of like proliferative diseases like PDR and Eales disease or the vascular occlusions, we can prevent vitrectomy by giving a trial of YAG hyalotomy. Thank you.
Yeah, nice presentation and excellent documentation of all the cases.
Thank you.
I agree. Thank you, Dr. Vinay. It was very interesting, especially to learn about the uses of YAG hyalotomy for BRVO, PDR-induced SHH, which we usually wait and observe, go ahead for surgery. So nice to give a trial before surgery. The unsuccessful patient, PDR patient, the opening was not possible, or it was not good enough to drain?
The opening was not possible, ma'am. Like even if we after increasing up to the pressure, the power up to 8 to 9 millijoules, and even with the more spots of like more than 7 or 8 spots, like it was not opening. So by increasing the power and the number of spots, like we may end up in creating more traction.
Correct. Okay. Fine. Thank you.
Thank you.
Thank you, Dr. Vinay. That was a nice presentation on hyalotomy. Thank you so much.
Thank you, ma'am. Thank you very much.
Dr. Vidya?
Hello.
Yeah, Dr. Vidya. Please start your presentation.
Yes. Hello. Hello, ma'am. Hello.
Yeah, you can start.
Yeah. Good afternoon, everyone. Myself, Vidya. My chief author is Dr. Hitashi, ma'am. Here is a case I'm reporting. Case report of interruption of 3 rings second to ocular blunt trauma. Introduction. Blunt trauma is an important cause of ocular morbidity and unilateral blindness in the children. It can cause both anterior and posterior segment pathology, which can impact the quality of life. Following a closed globe injury, classical damage to the ocular tissue anterior to equator is described as 7 rings of trauma. Here are 7 rings of blunt trauma to the eye. Central iris damage that causes sphincter tear and iridodialysis, angle recession, cyclodialysis, tubercular meshwork tear, zonular tear with subluxation, retinal dialysis. In every case of blunt trauma to the eye, it is essential to perform a complete ophthalmic examination. It is especially important to rule out the retinal tears, commotion retinae, choroidal ruptures, and optic nerve involvement, and glaucoma, as timely management of which has significant impact on the visual outcomes. Objective of the study is to report a case of disruption of 3 rings second to the blind trauma. Study design is I'm reporting only one case report. A source of data is from Vitro Retina Clinic on Tertiary Eye Care Center. Each day, here is a 17-year-old boy presented with a trauma to the right eye by cricket ball while playing. Following trauma, he had a defective vision in right eye associated with the pain and redness. And he also presented with a history of floaters in the right eye. There is no history of flashes, photophobia, and diplopia. No history of trauma to left eye, and no history of any spectacle use. Ocular examination. Distant right eye, distant vision is 6 by 9. In left eye, it's 6:6. Right eye lids are edematous, conjunctiva is congested, cornea is clear, and anterior chamber own Herrick grade 2, and AC is having 3 cells. Iris, a sphincter tear is present at 4 o'clock position. Pupil traumatic mydriasis is present and sluggishly reactive to light. Lens is clear and extraocular movement within normal range. About left eye, distant vision is 6 by 6. Lids are normal, conjunctiva is normal, cornea is clear, anterior chamber own Herrick grade 4, and AC is quiet. Iris is having normal color and pattern. Pupil 3 mm and round, regular and reactive. Lens is clear and extraocular movements within normal range. Glaucoma evolution. Right eye intraocular pressure with 32 millimeter of mercury, and left eye 14 millimeter of mercury. On gonioscopy examination, there is a widening of ciliary band in the superior quadrant, which is suggestive of one. Next, come to fundus examination. Right eye disc and vessel appears normal, and there is a Berlin's edema present. On peripheral indentation, we found bucket handle appearance like 12:32 to 2:30 clock hour, which is suggestive of vitreous-based avulsion. And left eye fundus disc and vessels are normal. Foveal reflex present. Peripheral retina within normal limits. Here is a OCT image of left eye, that is traumatic eye, showing Berlin's edema. And management part, as he was in angle recession glaucoma, and we advise for regular follow-up and explain about the warning signs like flashes and floaters which are seen in retinal detachment. Coming to discussion part, ocular injuries are the most common causes of acquired uniocular blindness in the children. Closed globe ruptures were commonest, that is about 62 to 62.2%, followed by open globe injuries, that is 18.9. Blunt trauma can cause variety of anterior and posterior segment injury. And in our case, we had iris sphincter tear, Berlin's edema, vitreous-based avulsion, and angle recession. Commotio retinae is retinal opaqueness as a result of intracellular edema and fragmentation of the outer segments in the peripheral retina. When it occurs centrally, it is called Berlin's edema. There is no known treatment. The prognosis is usually excellent, except in cases which are associated with a subfoveal choroidal ruptures with foveal hemorrhage. Coming to incidence part, incidence of vitreous-based avulsion after contusion is 60%, but it is rarely diagnosed. And 24% present with a retinal break within 24 hours following blunt trauma, and 49% after 6 weeks of blunt trauma. Vitreous-based avulsion associated with retinal detachment in about 26% cases. Because of this inherently strong vitreous adhesion, avulsion and concomitant plasma tears, retinal dialysis is common. Presence of this finding should alert the clinician to perform a careful examination of the pars plana, ora serrata, and retinal periphery when the eye becomes stable enough after 2 to 3 weeks of trauma, as the incidence of retinal dialysis and retinal TC is very high. And evolution of angle in almost important in all the traumatic cases. Angle recession is easily diagnosed by gonioscopy in first few weeks after trauma. Next, conclusion. Post-trauma cases, early and late intervention is a must for vision-threatening complications like retinal break, retinal detachment, glaucomatous, or optic atrophy. It is important to diagnose the risk factor for traumatic glaucoma so the ocular morbidity is prevented by appropriate therapy as early as possible. Thus, early peripheral retinal and gonoscopy examination is important, preventing morbidity after ocular trauma. Hello. Hello, ma'am. Hello, ma'am.
Yes, yes. Are you finished? Is that your last slide?
Yes, ma'am.
Okay. So which are the 3 rings that you're speaking about in your topic? Disruption of the
Ma'am, that is sphincter tear, ma'am.
Okay. Then the
And vitreous.
Yes. Okay. I like the fact that you've drawn the fundus and included the drawings of the angle and the fundus in your presentation.
Okay, thank you.
Yes. Would have expected that too.
Yeah, thank you for the nice presentation. The diagrams and the clinical features were nicely elaborated in your presentation. Thank you.
Thank you.
Yeah.
Thank you.
I think we're done with all the presenters, ma'am.
Yeah, I think. And, thanks. We all thank COSCON for giving us an opportunity to judge, to be a part of this free paper medical retina session.
Thank you all.
Thank you. Thank you. Thank you, Dr. Sandhya. Thank you, Dr.
Thank you. Both of you. Thanks, Dr. Pooja and Dr. Sandhya. Bye and good day.
Bye.